Hi, good afternoon. I'm Ellen Bubrick. Just want to say thank you so much to Dr. Henderson and the course directors for inviting me to speak. This is my only disclosure that's not relevant to this talk. So epilepsy is a huge topic, an exciting topic, but it's really too big for a 45-minute slot, but we'll do the best we can. So I'm going to unfortunately go a little bit quickly, but you have all the handouts, all the slides, so you can refer back to them. Epilepsy is a very common neurologic disorder. It affects 3.5 million people in the United States, 65 million worldwide. It's really very, very common. 3 times as common, I'll note, as Parkinson and multiple sclerosis combined. So when we talk about the sort of bulk of neurologic burden and disease, epilepsy is really up there. Just want to distinguish between a seizure, a clinical seizure, and an epilepsy syndrome. So a seizure is, we think of as a clinical manifestation of an abnormal and excessive group of cortical neurons that discharge abnormally, and the clinical manifestation associated with that. Whereas epilepsy is a term we think of as to indicate a tendency towards recurrent seizures that are unprovoked by systemic or neurologic insults, as opposed to an acute symptomatic seizure, say from having a sodium of 120 or something like that. We think of epilepsy as a group of related disorders, again, characterized by the recurrent spontaneous seizures. We used to indicate a diagnosis of epilepsy, you had to have 2 or more unprovoked seizures. I've crossed out the 2 now because there are times that even 1 seizure with enough other clinical data is enough to diagnose epilepsy. The International League Against Epilepsy has defined epilepsy as disorder of the brain characterized by an enduring predisposition to generate epileptic seizures and by the neurobiologic, cognitive, psychological, and social consequences of this condition. And those are all really important in thinking about epilepsy and caring for people with seizures. The definition now requires at least one, have to have had at least 1 seizure to be considered to have epilepsy. But you could also have 1 seizure and other risk factors that put you at higher risk for recurrence, and that to be considered treatment for epilepsy, to be considered for treatment. So you could have at least 2 or more unprovoked seizures to meet the definition of epilepsy, or 1 unprovoked seizure and the high probability of recurrence. And by that, we're usually meaning an abnormality seen on brain MRI or on EEG, or if there's other evidence, either genetics or on EEG of an epilepsy syndrome, a specific syndrome. We like to think about seizures as either focal onset or generalized onset. And as soon as I'm meeting with a seizure patient, that's one of the first things I'm thinking about after we've decided, is this a seizure? Once we've decided it's a seizure, which we'll get to in a little bit, I want to think about, is it focal? Is it coming from one area of the brain and then causing focal symptoms, or is it a generalized epilepsy? And that distinction is important for a lot of reasons. The most recent ILAE classification of seizures denotes this also. It's either focal, and in focal, you can either be aware and have preserved consciousness or have altered awareness. So there could just be like arm shaking or some other focal symptom with or without awareness, or there's generalized epilepsy with bilateral tonic-clonic convulsions. Or the other categories we don't know. Maybe we walked in and we just saw the end of a convulsion and we don't know how it started. So they've changed this taxonomy now in terms of how we denote seizure types. What we used to call simple partial seizures, we now call focal aware, which can include either a motor or a non-motor component. What we used to call complex partial, we now call focal unaware, or secondary generalized, now bilateral tonic-clonic. So we think about focal aware seizures. We're thinking about the area of the brain, one small area, one focus that's causing symptoms. So if the area of the seizure comes from the motor strip, you could see that there could be just full awareness, but arm shaking. There could be head turning and twitching of the face. There could be autonomic symptoms. If we're in the post-central gyrus or the somatosensory cortex, you may see a seizure just involving numbness or tingling of one limb. But again, focal aware, preserved awareness. focal impaired awareness, or what we used to call complex partial, you start to see a little bit more involvement of other areas of the brain. So instead of just shaking or numbness, you start to see confusion, confused or garbled speech. They could be wandering, blank staring. Sometimes they'll say, I was staring right at him, and it's like I was looking through him. He just wasn't there, but his eyes were open. You can see chewing or oral automatisms or manual automatisms. So that implies that there's a bigger area of seizure involved, of brain involved, but still focal. But any small seizure or focal seizure can progress to a generalized bilateral tonic-clonic convulsion. So even small seizures, any seizure can present that way, or they can just go right into a convulsion. So generalized tonic-clonic seizures, what we used to call grand mal. There's of course the tonic phase, the clonic phase, and you'll see this, sort of what you see in the movies, this big convulsive movements, sometimes with frothing at the mouth. Eyes are often can be blinking, or sometimes are open, and the jerking movements. There's a lot of different kinds of generalized seizures. The one I just mentioned that you see, sort of the big grand mal is the most classic, but there's a lot of different types. Technically, absence seizures are generalized, not to be confused with a focal impaired awareness seizure. And then there's also myoclonic, clonic. There's lots of different types, but mostly we're thinking about convulsions when we talk about grand mal seizures, generalized seizures. So this just denotes different throughout the human lifespan. There's a different differential in etiology in terms of age. So in children, less than 15, there's this large area of idiopathic and congenital. Adult epilepsy is really just the tip of the iceberg compared to the pediatric syndromes, which are way more common and more complex. So you have that sort of childhood component there. As we get a little bit into teenagers and young adults, take more risks. They have a little bit more trauma associated with seizures. Still some congenital. We start to see some infection and tumor as etiologies for seizure disorders. As we get older, the stroke is more common, tumor becomes more common. And then in the elderly population, you see that stroke and tumor are common, as well as degenerative neurologic disease in terms of sometimes seizure is the beginning symptom of Alzheimer's or other dementias. And age is important when we're thinking about epilepsy syndromes. Different syndromes start at different ages. There's childhood epilepsies, juvenile onset epilepsies, and adult onset epilepsies. So the age of onset is important, as well as location, which we can tell by the seizure semiology, what the seizure looked like clinically, as well as EEG features. And the sort of putting together the epilepsy syndrome is important in terms of thinking about treatment and prognosis. So we want to make sure that first we get the diagnosis correct. And there's a lot of things that can mimic seizures. So in terms of getting the diagnosis correct, we want to be very careful not to fail to diagnose or miss a seizure diagnosis. Seizures can be dangerous. You can die in a seizure. It's rare, but it can happen. There's we'll get into this a little bit later, but a higher rate of injuries and accidental deaths from seizures, as well as reduced quality of life due to recurrent events. So if they go undiagnosed, that's dangerous for the patient. But we also want to be careful not to misdiagnose and give patients potentially toxic medications that they may not need, and then possibly fail to treat what's actually going on. Patients with epilepsy suffer from a lot of social stigma, financial burden, and a lot of other things. So you only want to get the diagnosis if it's right. A lot of things can look like seizure. The most common probably that we see is syncope, but a lot of other things can sometimes mimic seizure, migraine, TIAs, some movement disorders, sleep disorders, of course, some psychiatric disturbances, sometimes recrudescence of old stroke symptoms. So let's do our first case. The first case is a young woman who came to see me many years ago with a history of spells since age 4, involving loss of consciousness, often precipitated by an emotional trigger. One time she reports she passed out while standing on a toilet watching her father shave. Another time after suddenly feeling hot in church. As a young teenager, it happened once when she was watching surgery on a dog, and again after cutting her finger. This started happening at one time up to 10 times a year, other times more infrequently. She had one at EEG that was read as abnormal, having generalized spike wave activity, and she has 2 relatives with epilepsy. Many years ago, her mother reported she had an event one year when they were abroad. She would report this sort of similar onset of lightheadedness, abdominal discomfort, a general feeling of being unwell. When they were abroad in Italy, it happened in a hot shower. She suddenly felt nauseated, lightheaded, blurry vision, went to lie down, and then lost consciousness. Her mother described that arms were extended out, whole body stiffened, eyes were wide open, seemed to be staring straight ahead, was unresponsive. They usually last about a minute, sometimes longer. And after the event, she doesn't quite know what happened, but she remembers the prodrome right before. She had an EEG, another EEG that was normal, and a brain MRI that was normal. And she had one event when she woke up very early at 3 a.m. to catch a plane. So here's the EEG, the video EEG that was happening at the time when we captured this event. So you can see right here is when first thing she said was, I think I'm going to faint, before she had this head version. So I think I'm going to faint. I can see a little bit of slowing here in the EEG, a slow burst here, flattening. Before she even says, I think I'm going to faint, if you look down, this is the EKG. She had a pause even before she said that. So if you look, this is, you'll have to just believe me, I'm going to the next one. This is artifact here, but this was 17 seconds of asystole. So she had this prolonged pause, and you can see her EEG's flat here when the brain's not getting any blood. And then this big hyperperfusion was where she had that big convulsive event. So that's convulsive syncope. And you can see her EEG, this responsive tachycardia, comes right back up, lots of eye blinks. She's kind of like, what happened? And she's responding and diaphoretic and tachycardic. So convulsive syncope, I use this every year when our new fellows come in to show them, it can look like a convulsion, like an epileptic convulsion. When there's a pause like that. So there's a few things we can use to try to discern between the two in terms of the history. Although with her, I really wasn't sure, and I really needed the video EEG to help me. They can both, obviously they both have loss of consciousness. Syncope can be seconds, seizures more on the order of a minute or two. Involuntary movements. The biggest thing that I use is that very reliable, trusty prodrome, where people will say like, oh, I feel like I'm going to go down. I feel like I'm going to go down. And they have this very commonly expressed, nausea, tunnel vision, whereas that is very, very specific for syncope. Afterwards, they often do remember the event. They often remember feeling that prodrome right before they lost consciousness, I should say. Whereas in a seizure, they are often outright confused after. And they don't know what happened. They don't know how they got on the ground. It's very frightening. They are totally amnestic to the event. And there's, of course, EEG differences too. So let's move to our second case. This is a 30-year-old woman with a history of spells for the past few years. They're preceded by what she terms a bad smell in her nose that it's hard for her to describe. Triggers are anxiety, coffee, sometimes drinking a lot of Red Bull, skipping meals. She's been intubated for this several times for ongoing convulsions. So this one, you can see, this is where the EEG on this patient during the spell, this is where the movements start. They start very abruptly. And her EKG is normal and her EEG is normal throughout the entire event. She's got a normal rhythm, posterior dominant rhythm, normal waking background. Everything looks normal during the event. She's a little bit tachycardic. This is a psychogenic non-epileptic seizure. A paroxysmal episode of movement, sensation, or experience that can look like an epileptic seizure, but not associated with the ictal signature that we see on EEG, often typically of psychogenic origin. You can see they're very common. They end up being referred to us about a third of our inpatient referrals for our epilepsy monitoring unit. It ends up being psychogenic. It's very common. You can read there a little bit about the recent treatment as a multidisciplinary approach with first involving neurology and then jointly with neurology and psychiatry and transitioning the patient to psychiatry. We do not use anti-epileptic drugs in this disorder because it's not epilepsy and it actually tends to make the events worse. Here you can see, I'm going to go quickly through this, but the clinical features often you can see thrashing, flailing of limbs, wild movements, pelvic thrusting, back arching. Sometimes it's on and off, waxing, waning, starting, stopping movements, and so on. There's some sort of clinical pearls. The next case is a 30-year-old man who started having spells at age 12. He reported he felt ill after eating a piece of chicken, sat up, threw his head back. His siblings reported he was acting like he was possessed. He reported anxiety attacks in college when he felt tired and stressed from school. He would feel his mind racing, heart racing. He would thrash about and scream. Sometimes people would see him screaming during these events, looking around for his meds, may or may not follow some commands. As he wakes up, he would say he felt his thoughts were racing. He remembered like parts of a dream as if he was in the movie The Matrix, as if aliens are communicating through me, is what he said. They sometimes would have visual hallucinations. He was tried on a lot of different medications, but still had several of these at night, rarely during the day. Positive family history of bipolar. This was a frontal lobe seizure, what we sometimes used to call pseudo seizure, where we were suspecting by how it looked that it could have been a psychogenic event. But this is an example of frontal lobe epilepsy. The frontal lobe is a complex place with a lot of complicated motor circuits, and you can imagine a seizure going on in that area can result in complex behaviors with motor agitation, strong emotional feelings, sometimes repetitive activity, pelvic thrusting, pedaling, thrashing, things that you sometimes see in a psychogenic spell. Often can be accompanied by loud vocalizations. The EEGs can be helpful. Sometimes it's hard to see, can be hidden in deep sulci of the EEG, but usually we get some hints on EEG. I didn't show his here, but it was helpful. So the diagnosis is really important. Once we have the diagnosis, or I like to think a little bit about how did this come about in this patient. I have the history there in capitals just to, the neurologic exam is always important, but in epilepsy, it's really about the history that's going to give you the best information. So the most important thing is if the patient can tell you how much they remember from the event, including what did they feel at the beginning, the aura, anything they remember during the event, and what they felt post-ictally. And if they don't remember, it's really important to call anyone who may have witnessed it. I'm often like on the phone with their coworker or the person in the locker room who saw it and say, what did you see? What did you experience? What did the person experience? What did you witness? That's helped me so many times when the patient doesn't remember. We always ask about, especially for new onset seizures, if there have been any prior events that they know of, any substance use that might be contributing. I ask about risk factors for epilepsy in terms of family history. Was there any history of traumatic brain injury, the birth history of febrile seizures, other things that could put them at risk? And of course, a full neurologic exam. Things that can trigger seizures in patients even with known epilepsy. Sometimes missing one dose of medication can be enough to trigger a seizure. So we always ask about adherence, which is a big problem in epilepsy. Lack of sleep, recent infections, or other metabolic stressors that could have potentiated the seizure. Again, drug use. Some people never can specify a trigger. They just happen randomly. So key questions in guiding the history. When I'm thinking, was it a seizure? I try to ask open-ended questions. What was the first clue you knew something was wrong? Did you have a warning? Has anything weird like this happened before? Sometimes people will have a first convulsion, then you ask about other spells, and they'll say, actually, yeah, sometimes I get deja vu and I'm a little confused after, and they sort of thought it was normal or didn't want to tell anyone. And turns out that had been going on for 5 years and it's part of their temporal lobe epilepsy. So ask about other kinds of spells, provoking factors we talked about. Try to understand the localization. What was the first thing you experienced? What was the first thing the witness saw move? Other things I listen for. Sometimes people just have a really hard time describing their aura. That does not make me suspect. It makes me more concerned it was a seizure. Sometimes people just say, I don't know, I couldn't explain it. It was a weird feeling. I felt something weird coming on. Sometimes it's just hard to describe. Sometimes they will talk about hallucinations or illusions, deja vu in temporal lobe epilepsy, automatisms. There will often be evidence of lost time. Sometimes people will say, I was reading my book and suddenly I looked up and it was an hour later than I remember it. Sometimes people will have a seizure and be postictal for a while and all of a sudden sort of wake up and realize, say, what happened? The lapses in time or periods where they're unresponsive. You'll sometimes get a history before a grand mal convulsion of what we used to call the epileptic yelp. And as we talked about, other clinical manifestations of convulsions. So there are AAN practice guidelines for new seizure evaluation. We always think about, especially in adult onset epilepsy, adult onset seizures, we always get an EEG and brain imaging. They end up getting lab tests anyway, because they're usually in the emergency room. They tend to be less helpful, but it's good to do the first time they present, just to make sure their sodium wasn't like 118 or something like that. Usually they're normal in epilepsy and not provoke seizures. Lumbar puncture, we really only reserve if there's immunosuppression or fever involved. The EEG can be really helpful. Again, we're back to, you can see if there's a focal discharge, like in the right temporal lobe here, or more of a generalized discharge to give you a sense of the epilepsy syndrome. That also helps guide treatment, as we talked about. A routine EEG is about 30% sensitive to pick up abnormalities, so we often need to do several if they're normal. Or we'll sometimes do like a 24-hour, 48-hour ambulatory EEG where we can see all stages of waking and sleep, which increases the yield of seeing an abnormality. So they'll often get a CT in the ER, which is fine for a screening test, but you really want to see a brain MRI in adults to make sure that you're not missing a tumor, but also to look for the etiology. Is there mesial temporal sclerosis or something that's causing the seizures? And the presence of a lesion affects outcome in terms of, as patients become refractory and ultimately be considered for epilepsy surgery. The presence of a lesion is really, really important in their outcome there. So let's move to treatment options in epilepsy. Mostly, I think this group will be most interested in anti-seizure medications, but in refractory epilepsy, we also think a lot about epilepsy surgery, which can be curative for some patients, and other devices, vagal nerve stimulators, responsive neurostimulation. You may have heard of NeuroPace. Devices that can be, these are devices that are implanted with permanent electrodes that can decrease seizure frequency over time. Dietary therapies are still very helpful in the pediatric population and also in adults who can tolerate it, and sometimes alternative therapies. So there's a huge list of anti-epileptic drugs, and it keeps growing. To not overwhelm you, I just try to break it down to a handful for each for a generalized or focal. If you don't know, and it's broad spectrum, if you don't know if it's generalized or focal, then you would use a broad spectrum agent, which is the generalized epilepsy drug. So you could use valproic acid, lamotrigine, levetiracetam, topiramate, zonisamide, sometimes lacosamide or clobazam. So if you don't know if it's generalized or focal or how it started, it's safer to use a broad spectrum agent. Focal epilepsies, we reserve carbamazepine and oxcarbazepine for focal epilepsies because they can sometimes make a generalized epilepsy worse. So if you're not sure, you usually don't start with one of those, or gabapentin, pregabalin, phenytoin, or perampanel. We always want to think about drug-drug interactions, not just with these medications with each other, but with all the other medications the patient is on. A lot of these medications are CY450 inducers. Some are inhibitors of other drug metabolism. I always try to tailor the drug choice to the person. So what other concomitant disease do they have? Do they also have insomnia? A lot of these drugs are great at making people sleepy. We'll talk about, do I need to talk about birth control? We don't use oxcarbazepine with oral contraceptives because it makes oral contraceptive ineffective, and so on. Efficacy, cost, all of those come into play. A lot of times I try to tailor it to see if they also have a mood disorder, which is very common in epilepsy, or anxiety. Some are weight gain drugs, some are weight neutral drugs, some are weight loss drugs. So again, it's all about trying to get the right fit. They're equally effective for the most part. Adverse effects, just like any set of medications, there's sort of the more sort of general or systemic rashes or organ toxicity, which is specific for each drug. Most of these drugs, the side effects that you're worried about, because they're neurotropic, they go past the blood-brain barrier, they work in the brain, they can cause drowsiness, sometimes dizziness, ataxia, sometimes depression or other mood or anxiety disorders. And some of the long-term drugs, we worry about osteoporosis. Despite all these drugs that we have to choose from and all of the drugs that are coming down the pipeline every year, there are still a portion of patients that remain drug resistant, as defined by the ILAE as failing 2 or more anti-epileptic drugs. So I just want to briefly talk about the burden of uncontrolled epilepsy in this refractory group. About 70% of patients will do well on one drug. They'll be seizure-free, and we work on minimizing side effects, and they come in and they're seizure-free and they feel good on their med, and that's a great day in clinic. That's 70% of epilepsy. But that means 30% are refractory and aren't doing well on their medication and are seizing anyway, no matter how many meds we try. So that's where a lot of us see a lot of those types of patients in our, that's when we start thinking about alternative options like epilepsy surgery, implantable devices, and so on. So the burden of uncontrolled epilepsy is large. Ongoing seizures can be very debilitating. They're associated with morbidity and mortality. I keep this picture up here of Cameron Bice, who my kids loved, who was a Disney actor who died of sudden unexpected death in epilepsy last year. There are high rates of depression and anxiety in patients with uncontrolled epilepsy. There's high rates of seizure-related injuries. There's burns, falls, other accidental deaths, and elevated suicide rate. In addition to the sudden unexpected death, which is 1 in 100 in patients who are being referred for epilepsy surgery. That's it's pretty high, very concerning. So the most important thing with patient who we're determining is drug resistant is to try to understand that as early in the course as possible. So we used to give all these drugs and wait all this time, and at the end say, maybe this person is going to do best with epilepsy surgery. We're starting to do that sooner now, so that even if someone fails one drug, I'm starting to think about, is there something we're going to be able to offer this person surgically? Even 1 seizure per year has been associated with a lower quality of life. So let's talk a little bit about women with epilepsy. Especially we have to think about this in women with childbearing age, periodically address their seizure medications and birth control plans, be aware of drug-drug interactions. We have a whole pregnancy and epilepsy referral service where we have our colleagues who do preconception counseling. We're starting to learn more and more about the safety of these drugs in pregnancy. And it's a delicate balance, caring for both the mother and safety of the baby. We have all these women of childbearing age on folic acid, and of course bone health, which we talked about. Despite the fact that some of these medications, mostly Depakote and folic acid and sometimes topiramate, can be teratogenic, many of the medications are actually safe to use in pregnancy. And so seizure control in pregnancy is really important. Most pregnancies in mothers with epilepsy produce normal children, but valproic acid and topiramate are associated with much higher rates of teratogenicity. Driving is a big question. I include, because it's a big part of the counseling of patients. Massachusetts has we are a non-mandatory reporting state, but I encourage all of our patients to report their seizure to the RMV. Massachusetts has a 6-month seizure-free period that's mandated before you can drive again. So usually in those first 6 months, you're going to know if your patient had a recurrence or not, but not always. So it's always a bit of a challenge. But I discuss it with patients at each visit, and I document that they understood the state law. There are epilepsy quality measures that I include here. From the AAN, I actually use this in my clinic note template just to make sure I reached each of these in the visit. We always want to ask about seizure frequency since the last time you saw them, what interventions you're doing to try to mitigate their seizures, that you've confirmed the etiology, seizure type, the syndrome. We always ask patients about side effects and how they're tolerating their medications. Some of these are just very, very toxic, and we want to mitigate side effects as much as possible. Safety issues, which we talked about, like burn injuries, no cooking while home alone, no swimming alone. We talked about driving. We always screen for depression and other psychiatric comorbidities or medication side effects. It's very, very important in this population. And women of childbearing age, we talked about, and then referral to treatment-resistant epilepsy to an epilepsy center. People ask a lot about discontinuing drugs. When can I come off these drugs? In general, if we know for sure it's a generalized epilepsy, those are thought to be long-term, lifelong disorders, and they often are unable to come off medications and remain seizure-free. There are some people with focal seizures that are able to. We usually recommend, we like to see a 2-year seizure-free period before we recommend coming off medications, and we would counsel them about their risk of recurrence based on their MRI, their EEG, and their neurologic exam. If all 3 of those are normal, they are in the lowest risk category for recurrence, but there's precious little in terms of what we can use to guide people. So it's a bit of a risk, and it's something that you just want to talk about with your patients. So we have 2 minutes for these questions. I'll just summarize, and then we have 2 quick questions. Epilepsy is a common disease, different causes and manifestations. Other disorders can mimic seizures, including convulsive syncope, psychogenic spells. History is key to accurate diagnosis, but MRI and EEG can also help you. There are a lot of therapeutic options. Education and safety counseling are really, really important. And I should have put on there about, early referral to an epilepsy center for anyone who's uncontrolled. We'll start with question 1. An adult, I guess they have a answering response system. That's good. An adult who presents after first seizure should have which of the following tests? Very good. Brain MRI and EEG. Good. And the second, to meet criteria for drug-resistant epilepsy, patient has to have tried how many seizure drugs before we call it drug-resistant epilepsy? How many seizure drugs must they have tried? Okay, sorry, that's me. That's me. That must have been my bad that I didn't do that clearly. So the answer is 2. So if you have failed 2 seizure drugs, you're considered drug resistant and should be referred to an epilepsy center for alternative options. Thanks very much. I'll leave it to Dr. Henderson if there's anything else I should cover.
Fantastic. Thank you, Dr. Brubaker. I do have a couple of questions from the audience. I think we have about a minute left. One of the questions include distinguishing between REM sleep disorder and frontal lobe seizures, and also make a comment regarding cannabis.
There's always a cannabis question. Always, always, always. Okay, let's do the other one first. So discerning between REM sleep disorder, REM sleep disorder, and frontal lobe seizures. So really good question. So the gold standard is to capture the event on EEG. REM sleep disorder is not a seizure, and so on EEG there will be no ictal correlate. There are changes in sleep state that you can see that they are in terms of their REM, but you're absolutely right. It's a really good question. It can look similar. You hear about people, throwing stuff in their room and like punching the wife and all this kind of stuff. Like there's some very bizarre motor things that can go on in those in REM sleep disorder as well. But it's not seizure, and on EEG, it will be normal background during that. Whereas in frontal lobe seizures, the other piece clinically you can use is frontal lobe seizures, even though they're bizarre motor-wise, they're stereotyped. So like the one I showed you, the frontal lobe seizure, we captured 7 of those in his admission, and they look almost the exact same every time. And you get hints on EEG.
10 seconds on cannabis before we move on.
Okay, cannabis. So that's like a huge thing right now because the cannabis lobby is like very excited. But so there is one multi-center study that showed that a pharmaceutical grade drug called Epidiolex was helpful in two very rare pediatric disorders, Dravet syndrome being one of them, and Lennox-Gastaut being the other. So those are two very rare pediatric epilepsy syndromes. There's really no great data on cannabis use in adult epilepsy. So there's a distinction. There's the one pharmaceutical grade drug, Epidiolex, it is available. We sometimes will use it on patients who look like they might have Lennox-Gastaut. Then there's medical marijuana, which is, of course, or any artisanal, you can smoke it, eat it, drink it, whatever way people grow it. But there's no medical data about that at all in epilepsy. Some people swear by it and they feel their seizures are better. Some people definitely noticed a worsening. So we don't recommend it. And that's through the American Epilepsy Society website. Also, there's a statement on this. We don't recommend it because there's no good data yet in adults, despite the media hype.
Great. Dr. Brubeck, thank you so much. That was really fantastic. And we learned a lot during that presentation.